For women, we usually think of there being two major common types of urinary incontinence, which we call stress incontinence, which is leaking urine typically with coughing, sneezing, or exercising, and urge incontinence, which is rushing to the loo and not getting there in time. These two common types of incontinence have slightly different causes, and much of my research has been on the genetic causes of these two conditions. But broadly, the most important things we think about that put people at risk of incontinence are getting older, gaining weight, and unfortunately having children, particularly delivering those children vaginally as opposed to cesarean section. Two major different kinds of incontinence, that's again stress incontinence and urge incontinence, do have quite different treatments. Across both, we commonly refer patients to see a specialist physiotherapist, first of all, for pelvic floor training. For stress incontinence, after that step, we can begin to think about surgical treatments. That can be injectable treatments to fill out the bladder neck, or it can involve a major operation to support and lift the bladder neck through different ways. For urge incontinence, rushing to the toilet, again, we refer patients to physiotherapy, but then we often think about tablet treatments as the second line of therapy. And those can be medicines to relax the bladder and help you hang on for longer. And only if these treatments fail, we tend often to think about injection of Botox, as people have for their wrinkles, and that can be extremely effective, injected into the bladder wall, preventing people from rushing to the toilet. There are home treatments for urinary incontinence. It's an important mainstay of treatment for all women who experience incontinence, that they optimize and maintain their pelvic floor strength through home pelvic floor training, often known as Kegel exercises. These can be taught by a physiotherapist. They can also be taught by an app such as the NHS Squeezy app, or supported by a number of devices that can help to learn to do it effectively. We also tend to give patients lifestyle advice on how to limit the impact of incontinence on their lives at home. That's a very important question. Many women manage to live with incontinence for a very long time and manage its effects using pads or other containment devices to limit the impact of incontinence on their lives. But if it's left untreated, it can have important consequences, particularly skin conditions around the vulva and perineum, or bladder infections that make it worth treating in its own right, not just as a quality of life issue. Conversely, though, women sometimes come through for treatment saying that they feel their incontinence is relatively under control at the present time, but they don't want it to get worse in future. And I don't normally recommend that we do just-in-case treatment for the future. It might get worse in future, but we shouldn't normally aim to be preventing future consequences. We should be aimed to be treating the symptoms as they are now. Well, that's a complex question. We do know that incontinence does get more common as patients get older. Both rushing to the toilet and leaking with coughing and sneezing get more common around the time of menopause, and get even more common as patients age beyond the menopause. However, you shouldn't think of incontinence as a normal part of aging. It remains an entirely treatable condition for the vast majority of patients, regardless of their age. If patients are worried about incontinence, they should in the first place consult their GP, who is well placed to start initial treatment recommendations or make a referral to physiotherapy or what's called a continence advisor, which is a community-based service for helping with these issues. And that should usually be your first port of call.